two beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare Podcast. This is our episode number 111. And today is a very special episode because I'm joined by my co-host, Dr. Jose Checo, but also one of the co-authors of our new book, Controversies in Critical Care, Professor Ian Seppelt from Sydney. Welcome, Ian.
Thank you very much, Swapnil. It's a pleasure.
Hi, Ian. Nice to see you.
Jose, it's a pleasure to talk to you.
So first of all, we have recently published this book, Controversies in Critical Care, which has addressed 52 controversies, and Ian is one of the key co-authors on this book. And the topic that we have chosen today, which is very close to his heart, that is selective digestive decontamination in intensive care. And he's also one of the main authors of SuDDICU trial, which was recently published in JAMA, which has also resurfaced this controversy, at least in Australia and New Zealand, but what to do with this SuDDICU concept in intensive care patients who are mechanically ventilated. So Ian, just to kick off the podcast, you have invested a lot of time and effort in designing the trial, then running the trial, and then obviously in publication of this trial. Can you just give us the outline of why this concept is really important and what are the kind of key principles behind the selective digestive decontamination in patients who are admitted to intensive care unit?
Yep, certainly. Firstly, I would just like to credit all the people that have been involved. The SuDDICU program that we've been part of has involved literally about 1,000 people over more than a decade, led by the Critical Care Division at the George Institute for Global Health in Sydney and Professor John Myburgh and team. But it's very much a large team effort, and I fully acknowledge the whole team. Selective decontamination has been topical in intensive care for 40 or 50 years. It's a concept that was first developed in the 1970s in haematology, and it was actually designed as a prophylactic measure to prevent hospital-acquired infection in immunosuppressed haematology patients by selectively killing potentially pathogenic organisms from the gut, particularly gram-negative pathogens, to try and prevent hospital-acquired sepsis while these patients were immunosuppressed. That was then translated into intensive care medicine in the 1980s, most particularly by researchers in the Netherlands, best known of whom is the late Chris Stoutenbeek. And since the 1980s, there have been more than 50 randomized trials looking at the role of selective gut decontamination in intensive care. So the technique is to use some non-absorbable topical antibiotics, typically colistin, an aminoglycoside such as tobramycin, and an antifungal such as either amphotericin or nystatin, which can be given into the mouth and the oropharynx and the upper digestive tract to not sterilize the gut, but to selectively remove these potentially pathogenic organisms. And usually, though not always, this is associated with a short course of intravenous antibiotics to particularly deal with organisms that might have been aspirated at the time of endotracheal intubation. So over the years, the large number of randomized trials have pretty much all shown a reduction in nosocomial infection using this strategy, and more than half have shown a mortality benefit using this strategy in critically ill patients. Yet despite that overwhelming evidence base, it hasn't been adopted widely into practice outside the Netherlands and that area of northwestern Europe. So the first question our group took an interest in, this is from about 2008 onwards, was really the question why. When you look at knowledge translation, why do we as intensivists not follow a strategy that has been examined in many trials that certainly reduces nosocomial pneumonia, probably reduces mortality, and in none of these trials to date was there any particular evidence of harm? Yet despite that, why were we not doing it? The answers aren't a surprise, but certainly reflect human nature, because the overwhelming concern we as clinicians have is the risk of resistance. So STD is perceived as being the use of prophylactic antibiotics, and we as clinicians are all terrified of generating antimicrobial resistance, despite the fact that there's no evidence that STD actually does that. It's very, very hard to get past those sorts of biases. And we've still found that more recently since the publication of our own trial. So to try and address that, and to also address the question of external validity, where pretty much all the trials to date had been done either in the Netherlands or in Western Europe, we started a collaboration. This included Brian Cuthbertson and his team from Canada, and the original plan was a four-nation collaboration, including Anthony Gordon from the UK and Paul Young from New Zealand, to do a large four-nation parallel group cluster trial of STD, partly to address the external validity. This treatment seems to work in the Netherlands. Does it work anywhere else, including North America, because the Americans won't believe anything that hasn't been tested in North America, and Australia and New Zealand. Unfortunately, there were major problems getting funding in all of those jurisdictions. Fascinatingly, while in Australia, our grant in 2014 to the National Health and Medical Research Council was the single highest scored grant in that funding round, and was judged as being overwhelmingly important. In the UK, at the same time, the same grant was rejected, and really rejected with extreme prejudice. And the grounds given were mainly that the evidence was already overwhelming and that we should not be doing another outcomes-based benefit trial, but rather studying implementation of something that was already accepted to work, even though people weren't doing that. So that was the view at the time in the UK, that they should not fund our trial because it was unnecessary because the evidence was already overwhelming. So ultimately, after multiple attempts over sort of 2014, 2015, 2016 to bring in other groups, including in Germany and Brazil, we were left with the need to go it alone in Australia, having had the trial funded with a significant amount of public money, but not able to secure money elsewhere. We had the power in a cluster crossover design to detect what we considered a clinically significant mortality benefit, and mortality was the primary endpoint, though there were multiple, both clinical and microbiological secondary endpoints that you can see looking at the paper. Frustratingly, in our final analysis using frequentist statistics, it was not quite statistically significant, though there was a very strong mortality benefit. However, SuDDICU was included in an updated meta-analysis led by Anthony Delaney in Sydney, and looking at the totality of evidence and using 4 different statistical techniques, but primarily a Bayesian analysis, we have 99.3% confidence that there is a mortality benefit using STD in critically ill patients. And we're very, very confident of that figure, while at the same time, we could not detect any evidence of the emergence of resistance, though we didn't have the power to definitively exclude that as a possibility. We also saw a reduced number of intensive care acquired infections, and particularly bloodstream infections in the ICU with STD. So two interesting points that are perhaps not completely appreciated by people looking at the study. The first is that patients receiving STD do not, in fact, get more antibiotics. This had previously been shown in some of the Dutch studies, but we also confirmed that. We tracked all antibiotics administered to patients both in the control and the intervention arm, and normalizing this in terms of daily defined doses, and tracking what each patient received per day, the results were the same. The two graphs were almost identical between the two groups. So while we are protocolizing some antibiotics when we give STD, the control group got random practice wild-type antibiotics to just the same extent. So it's in fact, while protocolizing antibiotic prophylaxis, we are not giving any more antibiotics than patients in the control group in usual practice. And that's not particularly well understood. The other point that's not well understood is the restricted inclusion criteria. We were looking specifically at sick ventilated intensive care patients who were predicted to remain ventilated at least until the day after tomorrow. So not patients that as a clinician we predicted were likely to get extubated tomorrow. That's actually only quite a small subset of our intensive care practice. Certainly in Australia now, that is only perhaps 20% of our intensive care population, where the vast majority are either intubated and ventilated for a short period of time, or in fact not intubated at all, but treated in other ways in the ICU. So STD only affects a small subset of the ICU population and a tiny subset of the hospital population. We're not giving any more antibiotics, and we don't appear to be causing resistance, and we're certainly preventing infection and 99.3% likely to be saving lives. So that's sort of the bottom line for STD trials to date, including SuDDICU. The final point I make about SuDDICU compared to all previous trials is that to do this, we contracted a pharmaceutical manufacturer under license and good manufacturing practice to manufacture both the oral paste and the enteral suspension used in SuDDICU. So this is not just the 3 drugs, but also all the excipients that are necessary to make a stable product. And this was tested for both thermal and microbiological stability through the duration of the trial. We could not find any information in any previous trial to describe a similar process. And as far as we can tell, in other trials, STD products were either made up at the bedside or in hospital pharmacies locally, but without the quality control, without the stability testing that we went through, but also without any standardization of all these excipients. To give an example of why that's important, we found very early in the trial some problems, particularly at one site, but this also happened at other sites, where nasogastric tubes were being blocked by the enteral suspension. That didn't cause any nasty patient effect, but there were some problems with some blocked tubes that had to be replaced. That was addressed by slightly adjusting the formulation, still the same basic drugs. Some of the other inert agents in the suspension were adjusted slightly to make a suspension that did not block up nasogastric tubes. But that sort of process, as far as we can tell, has not been gone through in any previous trial. So we are confident that we've done a trial with very, very good internal validity that appears to show a clinical benefit without evidence of harm using STD in an Australian environment with low to medium levels of baseline endemic resistance. And I think that's going to become important in subsequent discussion.
Thanks, Ian. So I guess that's a very comprehensive overview of the selective digestive decontamination. Also, congratulations on this massive amount of efforts that have gone through in conducting this randomized controlled trial, which is quite hard to pull off, as you outline some of the challenges that you encountered along the way. I want to highlight a couple of points. So one thing is about the design of the trial. Now, this is, as you mentioned, it was a cluster crossover trial. The ICUs went through a period of selective digestive decontamination and on a crossover.
It was 12 months, then it washed out, and then another 12-month period.
That's right. Correct. But when you look at the meta-analysis, it was interesting to find out that when the trials were done with individual randomization of the patient, they shown to have more benefit with STD compared to cluster crossover trial, and there was no benefit in those trials. Is that something inherent drawback of the design, or why do you think that's the difference there?
That's a very interesting question. There's also temporal effects. So in the literature, all of the individual patient randomized trials were done earlier. So these were in the 1980s and 90s. And in the last 20 years, all of the modern trials have had some sort of cluster design. Part of the reason for that is the literal effects on other patients in the ICU. So if you do a straightforward placebo-controlled randomized trial of a drug, the drug that you give to the patient in bed 1 does not affect the patient who's in bed 2 in any way. Using SDD, there is the potential for effect on other patients, particularly if we alter either the microbiome of the patient or potentially the microecology of the ICU. So in the last 20 years, it's been felt inappropriate to just have individual patient randomized trials because of the potential effects on the ICU microbiology, and instead to use clusters so that any effects on the overall microbiome can be studied. Ideally, this would be for a prolonged period of time. That's one of the criticisms that we've had of our 12-month crossover design. Some people say, well, that's not long enough to know whether you've developed a problem or not. That probably doesn't make much sense, in that there's no even small signal of emergence. And microbiologically, you would expect to see that signal emerge very, very quickly. In other sorts of studies, when antibiotics are administered, or even when people have a change of diet, changes in the microbiome can be detected very, very quickly, like in a matter of days. And we are going on to do some more work specifically on the temporal changes in the gut microbiome in a selected subset of these patients. That work has not been completed yet. But it's highly unlikely that there will be a problem many years down the track that hasn't been detected, at least in some way, early on. So while that criticism has been raised, probably not valid. Part of the reasoning for the crossover design, as opposed to our original plan, which was a large parallel groups trial, is firstly the increased power that comes from a crossover design in terms of statistical power, but also, interestingly, just from the point of view of site investigators, our original plan was to randomize ICUs to either implement SDD or to be a control unit throughout. But there were some site investigators that were actually quite unhappy with that, because they wanted to be involved in delivering SDD, and they were taking a 50% risk of being randomized to purely collect data and otherwise do nothing. So there was much better acceptance from our research community when we changed to a crossover design, such that every site did have the experience of using SDD for a 12-month period, and that they weren't just doing a whole lot of data collection.
I just ask you, Ian, of course, the microbial environment between Australia and India are vastly different, I would suppose. We have a relatively high incidence of multi-drug resistant, especially gram-negative organisms. So given the fact that this is SDD has not really been studied in that kind of setting, what would you suggest? Should we embark upon a trial first of all, or do we follow SDD straight away? What is your take on it?
I don't think anyone knows the answer to that. That's a very, very topical question. There's certainly some consideration of how to do an SDD trial in India or more generally in South Asia. And my colleague Bala Venkatesh from Brisbane is looking at doing that right now, or at least looking at the feasibility of doing that. In terms of microbiology, while again in India you have a significant problem with resistant organisms, but at least theoretically SDD could help that, because if you can selectively eliminate these resistant organisms and combine that with a disciplined approach to antibiotics and antimicrobial stewardship, to me, it makes sense that you'll actually help your patients. If we come back to Europe in the 1980s and 1990s, STD was actually introduced in specific ICUs as part of a strategy to deal with an outbreak of severe gram-negative resistance. So while this is at a single ICU level, there are a number of published instances of an ICU with a major gram-negative resistance problem, introducing STD to actually deal with that problem and to selectively get rid of these severely resistant organisms from the gut using antibiotics that are safe administered enterally, even if they're toxic when administered intravenously. So at least theoretically, this could be quite beneficial in an environment like India. It certainly hasn't been tested in that context, and I think to be broadly accepted needs to be tested and needs to be tested in a trial. Hopefully that will happen, though it'll be a large undertaking if it is.
That's an interesting point, Ian, because another interesting aspect from the meta-analysis that jumps across is the benefit of SDT only in conjunction with IV antibiotics. And that has been, again, kind of considered to be a major challenge, because in order to be SDT to be effective, it has to be administered with IV antibiotics to show mortality benefit. If you don't use IV agents, in fact, it might be not useful or harmful. So I guess which IV agent to choose is going to be the critical question based on which environment you practice in. So what's kind of your thoughts on that? Why there is a difference we using the IV agent in conjunction with STD?
Yeah, it's kind of a non-issue, to be honest. This again is something that people got very, very concerned about, and some people remain very concerned about. But when you look at the sort of patients that we're recruiting, 75% roughly were already being prescribed broad-spectrum IV antibiotics for clinical reasons. So the vast majority of these sick ventilated patients whom you predict are going to remain ventilated are already receiving antibiotics because you've prescribed them, regardless of whether you're using STD or not. And provided patients were receiving an antibiotic from a list of antibiotics that we defined as suitable, then there was no change in the intravenous antibiotics for the trial. So it's only the 25% who were not receiving appropriate antibiotics at the time of recruitment who then received protocolized IV antibiotics. And for the trial, we used a third-generation cephalosporin because the Dutch did. And if there was a problem with allergy, then ciprofloxacin, again, because that's what the Dutch did. But that was only a minority of patients, and almost none in our trial actually got ciprofloxacin in that context. But because we already use antibiotics, these are sick patients, they're septic patients, the IV component, I think, is much less of a concern. Certainly looking at things such as the Cochrane meta-analyses, when we were designing the trial, it was reasonably clear from the Cochrane meta-analysis that was current at the time that there was this difference in outcome in those trials where there was an IV component as opposed to oral and enteral without an IV component. So we deliberately included that as part of the study because there was that signal in previous meta-analyses. But I think, in fact, and we've got the data to confirm this, 3/4 of sick ventilated patients whom you predict to stay ventilated are getting antibiotics whether you like it or not.
I think that's an important point, because if you look at our ICUs in India, for instance, many of our patients who are on ventilation would be on antibiotics anyway. And if you protocolize it and make a list of STD compliant antibiotics, perhaps that would be the way to go. The other thing I wanted to ask you, I couldn't find any data on the incidence of ventilator-associated pneumonias in the paper. Do you actually have data on it? Did it actually reduce the incidence of VAPs?
So it's very hard to define what VAP actually is. And because we were limited to clinically available data from sites, we couldn't do anything specific for the trial. So it was just what investigators reported. Because of the difficulty defining what VAP is, if you don't do things like protected brush specimens and use special microbiological techniques, the identification is all over the place in other studies. So we can't say for sure that we do decrease VAT per se. We are confident we decrease mortality. And in terms of the microbiological endpoints, looking at new culture results from normally sterile sites, we found fewer new infections and fewer new resistant organisms and fewer bloodstream infections. So I think that's consistent with the expectation there's less VAT, but we did not record that specifically.
Thanks, Ian. Another interesting point that I wanted to touch upon is what are kind of challenges in running this trial? Because as you said, we're still struggling to translate these significant results into practice changes. We have seen in the past some trials which did not have significant internal validity, but they managed to change the practices. While this trial has a very strong internal validity, along with the backed by this meta-analysis, but we are still even struggling to change our practices within Australia and even in Europe. Apart from Netherlands, no other country has adopted these practices. What do we need to do next now in order to translate these results into clinical practice?
The biggest issue is the lack of a convenient, commercially prepared product. So we manufactured our own for the trial, but that was specifically for the trial. Since then, there has not been any convenient manufactured substance that you could just go out and buy and give to patients. So anyone that wants to do this has to go back to the way it's been done in the Netherlands and get a local pharmacist to mix up something, or even get nurses to mix up at the bedside, which is difficult and potentially messy and requires a lot of local enthusiasm and input. Until a manufacturer comes up with a readily available commercial preparation, I think we're going to struggle to get uptake. Associated with that, there is a global shortage of colistin at the moment. That's only temporary, perhaps partly related to the COVID pandemic and some increased usage. The colistin manufacturers will certainly catch up. There's nothing special about the manufacture. There's just a time delay. But combined with the colistin shortage globally and the lack of any manufacture, we're having trouble with uptake. The other reason remains the skepticism of some people, particularly in the microbiology and infectious diseases community, who, despite the findings, are still looking for, but you didn't quite study this, you didn't do this, and you need to think about this and change this and do it again and do it again and do it again, rather than acknowledge and accept the results. One of the challenges for doing the study, because with the cluster crossover design, we determined that SDD was a routine protocol for the participating ICUs for that period. So it was the SDD protocol, which is no different to your DVT prophylaxis protocol or your stress ulcer prophylaxis protocol. And the unit of randomization for this trial was the entire ICU rather than the individual patient. So it was ethically approved to randomize patients without consent because they were receiving what was usual practice for the ICU at the time. And in order to do that, we had to have acceptance of all of the intensivists and all of the infectious diseases physicians in the ICUs to follow the protocol for that period of time. So unless both craft groups signed off this protocol and said, yes, for 12 months, this is our ICU protocol, this is what we offer our patients, then it wasn't possible to participate. And we certainly had a number of ICUs where the intensivists were enthusiastic. The ID physicians vetoed it. I think there was the other way around. There was more interest from the intensivists, but just still this concern about resistance from the ID physicians, despite the lack of evidence.
So I guess, do you think now, do we need another trial to address this, or what's your plan in terms of moving forward and getting this off the ground again?
Yeah, so our group through the George Institute is looking at this at the moment. Certainly, I don't think there's any need for another randomized trial in our environment in Australia or in in Europe or anywhere with low endemic resistance, we potentially need some sort of implementation study, and that's being canvassed at the moment. In environments with very different microbiology and higher rates of endemic resistance, there probably is a place for another trial, and this certainly includes India and South Asia, Southeast Asia. So if everything works out, I'd like to see some sort of repeat of the trial in, say, an Indian or South Asian environment, plus an implementation study in Australia with lower endemic resistance. And there's certainly places for all of that. I don't think anyone has the energy or the enthusiasm or the money to redo an RCT in our Australian environment, and that would be a minor tweak. Do we really have to do an RCT of a minor tweak of something that has already been studied? And another trial that is being looked at the moment in Australia and New Zealand is a trial specifically of intravenous antibiotics in a neurologic cohort of patients who don't routinely receive antibiotics. There's been 2 RCTs worldwide, including a French trial in out-of-hospital cardiac arrest, showing better outcomes, a short course of cephalosporins as opposed to nothing in that context. And these patients would have made up the 25% in SuDDICU that aren't routinely given antibiotics. If it's a pure severe neurological injury without sepsis, without aspiration, without pneumonia, without anything else to go with it. So there's, I think, room to study that particular question in severe neurological injury in ventilated patients. Do we have a short course of antibiotics or not at the beginning? And a trial addressing that has been designed by Paul Young from New Zealand, and our SuDDICU team is associated with that. But that's a slightly different question to what we looked at in SuDDICU with STD.
Yeah, and I agree. And I think that, as I said, the whole fascinating part of this whole concept for me is, despite the available evidence, how hard it is to change human behavior. And I
absolutely.
think that's the biggest, like, single center reverse trial change entire fluid resuscitation practice across the globe very quickly. But multi-center randomized controlled trials with thousands and thousands of patients with proven results is still not able to change the practices. That's the most fascinating part.
Absolutely.
So thanks for joining us today. And it's very valuable insights from the person who is involved in the trial and run this trial for last almost decade or so. It's really great to have you on the episode today.
It's been a great pleasure chatting to you, Swapnil, and to Joes. Certainly this program is not over. There's a lot more work to do, both with SuDDICU itself, our microbiological and metagenomic work, as well as the lead-on work that I've alluded to for an implementation study once a product is manufactured in Australia for a South Asian trial. So you'll hear a lot more about this, and this is going to go on for a while yet. But I genuinely believe that there's a patient benefit that can be gained here. And coming back to our most recent meta-analysis, using each of the different techniques in the meta-analysis, the number was almost the same. And we're 99.3% confident of a mortality benefit based on those data.
Thanks a lot, Ian, for joining us. It was a pleasure to have you.
Thank you very much, Joes. Thank you, Swapnil.
Thanks, everyone. Thanks for listening. We'll be back in a fortnight's time with another episode. Till then, goodbye and have a nice time.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.